technology.
All right. Well, I mean, you're about to live through the schedule, so I won't go through everything one by one. Oh, okay. Well, I'll introduce myself. I'm Matt Seymour. I'm the president of the board of the Chicago Asthma Consortium. I'm also the executive director of Mobile Care Chicago. So we have asthma and allergy clinics that travel around the city and partner with local schools and other community organizations to provide free ongoing medical care for people with asthma and with allergies. And then through the board of the Chicago Asthma Consortium, we have a variety of partnerships that we work on and committees that work with the CAC. And I think in the next slide, we'll get a sense of what the mission of the CAC is and what some of those committees are. So Rochelle, can you move the slides forward? Okay, well, all right, so that was the cliffhanger. Well, this is today's schedule. We have a brief overview and and a general welcome. And then we have 2 different panel discussions, and we'll have a little break in between. Just one quick note, you won't need to be on camera, and you won't need to unmute yourself to participate in this conference. We'll be going exclusively through the chat. We have moderators who will be sort of collecting questions that come up throughout all of the presentations. And then in the question and answer session, we'll be reflecting those back out to the participants so that they can make sure that they answer all of your questions. Next slide. So this is what I was talking about the CAC. First, so our mission is to improve the quality of life for people with asthma through advocacy, education, and collaboration. We have a variety of ways that we do that, but generally, you know, the way in which we do it is by convening stakeholders from across the city from a variety of different sectors to all come together to advance quality of life for people with asthma. And that includes medical and public health professionals, business leaders, government agencies, community-based organizations, and individuals, either those who have asthma, those who are caregivers for people with asthma, or people who are passionate about asthma issues and the sort of like cross-connected issues of air quality, housing, racial inequity, and to bring together all of those folks to make sure that we're working towards a more equitable society and greater resources for people who have the disease asthma. You can help out. You can go to chicagoasthma.org to learn how to be a member or to contribute. You can also join our volunteer committees where a lot of this work takes place. So CAC is a volunteer-driven organization, and we through a variety of different initiatives, we do community engagement. We also do professional development for people who are in the asthma community or are working with people with asthma. We have a community advisory board, a membership committee, and policy and advocacy work that we also do throughout the year. We are accepting applications for our board of directors. So if you're a person who is passionate about asthma and you want to connect and work with other people who are passionate about these issues, by all means, you can reach out to me either in the chat or by email, or you can contact info@chicagoasthma.org for more information. And then, so the conference objectives, I know these were circulated out in advance, but just to kind of keep everybody on the same page. So the first one is just an overview of the latest data from the city, county, and state levels, and to just get a pulse from our presenters about what they're looking at and kind of the different factors that are playing into asthma issues these days. To explore the current landscape, the impact of current policy on patients' asthma coverage, care, and medication, and advocacy efforts that are currently in the works to try to advance more equitable access to resources for people who have asthma. And then to reflect on partners and community resiliency, specifically creative ways to provide care and diversify funding, and also community support. What does it look like to support people with asthma at this particular time? So with that, I'll pass it over to my colleague, Dr. Anna Bullerman, to get us started, and she'll be moderating panel 1. So Anna, thank you for being here, and I'll pass it over to you.
Fabulous. Thank you so much, Matt. It's an honor to be here, and I'm excited to be kind of introducing this group of individuals who will be focusing on data related to asthma across the state of Illinois, as well as more locally in Cook County and in the city, followed by kind of a deeper dive into considerations related to coverage and access to care for asthma. Across the state and locally. So the panel will include 4 individuals. First, we have Nancy Emerson, who is an epidemiologist at the Illinois Department of Public Health, followed by Ajanta Patel, who's the medical director for chronic disease prevention and health promotion at the Chicago Department of Public Health. The panel also includes Amy O'Rourke, who is the director of chronic disease prevention and control at Cook County Department of Public Health. And finally, Christina Hamilton, who's the Director of Advocacy for Illinois and Iowa through the American Lung Association. We'll start with each of the individuals providing a presentation, that includes data and considerations. And then we'll open it up for questions and discussion at the end. Feel free to throw in any reactions or questions or clarifications along the way. To kind of support the conversation, and I'll be sure to include those at the end. So I will first turn it over to Nancy to get us started.
Thank you. Let me get Sharon. Okay, so excuse me. As Dr. Bullerman said, my name is Nancy Emerson. I'm a chronic disease epidemiologist with IDPH. I've been in this role since October 2010, and I was thankful that I was asked to be included on this panel. So I'm going to kick off the panel today by talking about statewide asthma prevalence, discussing our emergency department visit and inpatient hospitalizations. I have one slide about mortality, and then a little bit about access to care and what's going on in the state programmatic wise. So 9% of Illinois adults have asthma. This figure is from the 2024 Healthy Illinois Survey. At the base of the bars, there's some indicators for prevalence. So what we see in gold is that there's significantly lower rates of, or lower prevalence of asthma in the older population, age 65 years and older, in males, in non-Hispanic, Asian, and the Hispanic population, and in those without a disability. And then the red icons are indicating where we see a higher prevalence of asthma, which is true for females, the non-Hispanic white population, the non-Hispanic multiracial population, and then those with a disability. If you're not familiar with the Healthy Illinois Survey, it is a new web and telephone-based survey that goes to adults in Illinois. It's very similar in methodology to the BRFSS. And then my source for our childhood asthma prevalence is the National Survey of Children's Health. Their most recent data is from 2022 and indicates that current asthma prevalence for Illinois is around 5.3%, which approximately affects 150,000 children in Illinois. The Healthy Illinois Survey also allows us to look at adult asthma prevalence by county. We have 4 counties that have significantly higher adult prevalence rates than the rest of the states, indicated again by the red icon. Sangamon County has the highest rate, followed by Henderson and Carroll County, which is along the Iowa border, and Stark County near Peoria. There are 5 counties that have significantly lower adult asthma prevalence compared to the rest of the state, indicated with the yellow icon. So DuPage, right outside of Cook County, Calhoun, Fayette, Randolph, and Perry counties, which are all rural counties kind of in southern Illinois. And just to point out, you can see kind of a dark spot there at Bond County, that's next to Fayette, has one of the higher rates. However, the confidence interval is very wide, so it's not actually much different than the 9% that the rest of the state is seeing. Regionally, we see the highest rates of asthma prevalence in the Metro East and the Champaign regions, which is the yellow and orange regions of the state. Chicago, in this table, you can see Chicago has a prevalence similar to the state at 9.1%, according to the Healthy Illinois Survey. And suburban Cook has an area that's a little bit significantly lower than the state at 7.3%. Here are the overall trends for asthma as the primary reason for ED visits or for inpatient hospitalizations. You can see in both cases before the COVID-19 outbreak, the rates in Illinois were relatively stable. They had that drop in 2020, and now sort of post-recovery, the rates are increasing, but they remain below the pre-COVID numbers. So in 2024, the hospitalization rate was 4.1 per 10,000, and the ED visit rate was 40 per 10,000. Here's a quick look at trends, the trend graphs by age. There is a 2 to 5 times higher rate of both ED visits and hospitalizations in kids under the age of 10. So those are the 2 top line graphs compared to the older age groups. And then when we look at trends by race and ethnicity, the rates are 5 to 6 times higher in non-Hispanic Black, which is the pink line at the top. Utilizing data from the Illinois Hospital Discharge Dataset, we made new county level maps. These maps may be different than what may be posted or have previously been released because they are have been supplemented with data from the surrounding states. So we were able to get data from Wisconsin, Iowa, Missouri, Kentucky, and Indiana to supplement these county level rates to really make sure we're telling a more true picture with our border states. So the darker the color means the greater the rates. And right now you can probably draw into Hardin County down there in Southern Illinois has the highest ED visit rate. Other high rates are in Vermilion is the second highest, which is on the Indiana border in East Central Illinois, St. Clair County, which we call the Metro East, Macon County right there in Central Illinois as well. So we also created our ED county level maps to look at race, ethnicity, and also by age. And so this display I know is overwhelming, but it's a quick way to do a side-by-side comparison. So when you're looking at those first 2 age-related maps, you can see that the same areas of the state are kind of popping out for adults and for youth, particularly Hardin County in Southern Illinois. Maybe that Metro East area is a little bit darker, especially in the youth. And then the East Central Illinois area next to Indiana and up in Stevenson County on the northern border. When it comes to the race and ethnicity maps, we can see most of the color in the central and north for non-Hispanic, Black, and Hispanic. The non-Hispanic white is pretty similar to the overall adult map. And then down at the table at the bottom, I wanted to highlight some of the data that's happening in this area, Cook County, and then the surrounding collar counties. I want to draw your eye, though, to the very bottom row, which is our state total. You can see that the youth rate is almost twice as high as the adult rate. And again, the same sort of disparities that we're seeing as the non-Hispanic Black rate is in the thousands compared to the other race ethnic groups, which are at 151 and 278. This is our asthma inpatient rate by county. The highest rates are clustered down there in Southern Illinois, Alexander, Massac, and Hardin counties. Then you see St. Clair County in the Metro East and Henderson County up on the Iowa border. So looking at our side-by-side comparison of the inpatient hospitalizations, we do see a lot of data suppression for the rates. They're suppressed when the counts are less than 20, and this is over a 4-year period. When you look at the first two age-related maps, with the exception of the Metro East, there are different counties that are kind of popping for youth compared to adults. So not as much overlap like we saw with our ED visits. And then when it comes to our race ethnicity maps, I think you do see the Metro East, especially for the non-white population, but you do see different counties that we can explore based on the population. And then down at the bottom of the table, again, to draw your eye to the bottom row, the youth rate is more than twice the adult rate. And again, the same disparity where the non-Hispanic Black rate is in the hundreds compared to the non-Hispanic white and the Hispanic group. Now to switch gears, I only have one slide on mortality. This is where asthma is the underlying cause of death. The first graph shows death counts by year, where we see about 102 Illinoisans have died from asthma in 2023. Not displayed are the overall rates associated with these counts. These not displayed rates show that the 2023 rate is significantly lower compared to 2019 and 2020. Also not displayed are rates by sex because there were no significant difference. And unfortunately, I'm unable to display rates for Hispanic origin due to small numbers, but you can see the disparity between Black and white when it comes to mortality. You see in 2023, the Black mortality rate was 3 times higher than the white rate. It's also noteworthy that the mortality rate among Blacks was significantly lower in 2023 compared to 2019 and 2020. Looking at a few access to care measures from the Healthy Illinois Survey, there's a little bit of good news in here. So more adults with asthma had health insurance compared to those without asthma. More adults with asthma had a routine checkup in the past year compared to those without asthma. So those are good. That's great news. And then we can look at, this is self-reported insurance coverage through the Healthy Illinois Survey. So people without asthma had a higher prevalence of having an employer plan, pretty similar when it comes to private plan and Medicare and other. There was a higher prevalence among those with current asthma being on Medicaid compared to those that do not have asthma. And then there was a higher amount of people without asthma that were uninsured compared to those with asthma. Other good news is that more adults with asthma had their flu shots compared to those without asthma, but those rates are still around 50%. And then less adults with asthma had a dental visit compared to those adults that did not have asthma. So in summary, I hope this helps kind of solidify who is the most affected. We see children in the non-Hispanic Black community and where different communities are at risk or have higher disparities than other communities. And there's a few factors that are influencing why our certain counties and communities have those disparate rates of asthma prevalence, ED visits, and hospitalizations. There could be a lack of access to regular preventative health care that can lead to poorly managed asthma. Local environmental conditions can play a role. This could include exposure to triggers in the workplace, occupational hazards, or in the general environment. So certain industries or agricultural practices in specific counties could contribute to higher local asthma rates. Poor air quality is a well-known trigger for asthma. So there could be local pollution levels that are creating hotspots. And then older buildings are more likely to contain asthma triggers like mold, dust mites, and pets. And this condition of housing and school infrastructure is probably a critical factor given the highest ED visit rates that we see in our youngest age groups. So at a state level, the Illinois Asthma Program has made several investments and initiatives to address asthma disparities. Statewide, there are programs for asthma education for providers, community health workers, caregivers, and individuals with asthma. There's quality improvement initiatives and an effort to evaluate the impact of the rescue program. For those unfamiliar, rescue provides emergency asthma medication in schools. In Cook County specifically, we fund the Chicago Asthma Consortium. which for this conference, they provide community and healthcare professional education. They also support a mobile van project, which supports Mobile Care Chicago and the Lake County Asthma Van. We also have a coordinated care project in Chicago, which is made up of 4 different organizations. And it is an effort that starts with different school initiatives and links to clinical referrals. There's also 3 home visiting programs in Cook County and an additional program outside of Cook County. And we also fund the Respiratory Health Association for asthma self-management education, vaping education, the caregiver handbook creation, and other educational resources. So the state is very fortunate to receive funding from the National Asthma Control Program, as well as state dollars in our budget. We collaborate with the tobacco program to collect asthma data through the Youth Tobacco Survey. And one of our biggest resources for the asthma program in the state as a whole is the Illinois Asthma Partnership. They've been contributing thank you members over the past 25 years. They help shape our priorities, our policy agenda. They chair our work groups, and have been really integral to me as an epidemiologist as we think about the projects and the products that we want to put out. And they're also integral in shaping the state asthma plan, which gives us a framework for addressing asthma in Illinois. So with that, I will close. Thank you. And I will pass it off to, I think, Amy.
Great. Thanks so much, Nancy. Rochelle, were you able to pull up the slide deck?
Yes. Give me 1 second.
Thank you so much, Rochelle.
No problem.
While Rochelle's pulling up the slide deck, I'll just, again, introduce myself. So again, my name is Amy O'Rourke, and I serve as the Director of Chronic Disease Prevention and Control at the Cook County Department of Public Health. And I do want to just acknowledge and appreciate my colleagues at the Cook County Department of Public Health Epidemiology Unit, specifically Nan Nguyen, for support with preparing the slide deck that reflects recently released data. So we had some data that was hot off the presses for 2024, and he worked quickly to incorporate that data. So you're seeing the most current data we have. So thank you, Nan. So with that, you can advance to the next slide. So Cook County Department of Public Health, we're the state certified health department for 2.5 million people in about 127 suburban Cook County municipalities, excluding Evanston, Oak Park, Skokie, and Stickney Township, each with their own mayor, so again, home rule jurisdiction. It's a complex jurisdiction spanning more than 700 square miles, and we work with many community partners who advance health equity for all. Next slide, please. So in today's presentation, I'm going to be building off of some of the data that Nancy presented and really focused on suburban Cook County. What we're seeing as far as emergency department visits, prevalence, hospitalizations. So we'll dive into this data a bit more, as well as what we're doing, programmatically and to influence policy systems and environmental approaches to improve asthma disparities. Okay, next slide, please. So when we're looking at adult asthma prevalence, what we're seeing is Cook County overall self-reported adult prevalence is about 9.8%, which was consistent with 2019 report. Asthma in adults is most prevalent in the west and south municipalities of suburban Cook County. So communities like Maywood in the west, Markham and Matson in the south. On this map, you'll see the darker the blue, the higher the reported asthma prevalence. It's important to note that this data did come from the CDC, and there's no new CDC asthma prevalence data since 2022. So that's what this map represents. Next slide, please. Now we're going to look more closely at asthma-related ED visitation, utilization. It's important to note that we look at ED as you all know, utilization as an indicator of uncontrolled asthma. And so what we're seeing is after decreasing since 2020, we're seeing sharp increases in subsequent years. ED visits rates among each group remain pretty consistent 2016 to 2019. ED visits in 2020 throughout this presentation should be interpreted with caution due to the COVID-19 pandemic. We have observed increases in asthma-related ED visits for both adults and children since 2020, more significant increases for children over the last several years. Next slide, please. When we're looking at adult asthma ED visits by zip code, more recently in 2023, 2024, we're seeing that most prevalent, these ED visits are most prevalent in the West and South municipalities in suburban Cook County. Next slide, please. Unfortunately, this aligns with another map that we often look at and leverage at CCDPH called the Social Vulnerability Index. When looking at the previous map of asthma-related ED visits among adults, that map looked very similar to CCDPH's Social Vulnerability Index map, which we use to assess vulnerability of a community in the event of a disaster or public health event like COVID-19. So it's important to note that, again, when we're talking about the variety of factors that are leading to poorly controlled asthma, we have to look at the community at large, the variety of indicators or social determinants of health that drive these inequities. Next slide, please. When we're looking at asthma mortality, what we're seeing here in suburban Cook County, it follows similar trends in Illinois and US rates. Suburban Cook County mortality rates remain lower compared to Illinois and the US. So the mortality rate for suburban Cook County, it's the dark blue line under Illinois and US. Next slide, please. So now we're going to take a look more closely at asthma-related emergency department visits by age in suburban Cook County between 2026 and 2024. ED visits for asthma are higher among children and young adults. That's the teal bars that you see on the screen. Dark bars represent 20 and over. Rates among each group remain pretty consistent again between 2016 to 2019. Rates in 2020, again, recognizing COVID-19 pandemic. So ED visits came down, asthma-related ED visits came down. We have observed increases in adults and children since 2020 with large increases in asthma-related ED visits among children in 2021, 2022, higher than pre-pandemic and remaining high in 2023, 2024. We're also seeing increases in adult populations as well. Next slide, please. We're now going to take a closer look of asthma-related ED visits by race and ethnicity between 2016 and 2024. To orient you to this chart, all age groups are included in this figure. The dark teal represents non-Hispanic Black, dark blue is non-Hispanic White, light blue is Hispanic, and light teal is non-Hispanic Asian. Something to keep in mind is asthma-related ED visits are consistently highest among non-Hispanic Black populations, disproportionate to their share of the whole Cook County population. Rates are additionally high among Hispanic populations and lowest among non-Hispanic White and non-Hispanic Asian populations. As you can see from the data in 2014 that's on this chart, we're seeing non-Hispanic Black populations visiting the ED as a result of asthma about 11 times higher than non-Hispanic White populations. And again, keeping in mind, this is all ages. Now we're going to take a closer look at ED visits by age and race and ethnicity between 2016 and 2024. Next slide, please. So just to orient you to the data that's here, the solid line, again, represents youth. The dashed line represents adults. Dark red lines represent non-Hispanic Black. Teal lines represent Hispanic. Purple lines represent non-Hispanic White. So again, similar trends are observed as in the previous slide, showing that disparities between non-Hispanic Black and Hispanic populations and non-Hispanic White populations are prevalent among both youth and adult groups. Rates appear similar among non-Hispanic Asian and non-Hispanic White youth aged 19 and younger, and are lowest among non-Hispanic Asian and non-Hispanic White adults. You can see disparities between both non-Hispanic Black and Hispanic populations on this graph. Next slide, please. Asthma-related ED visits by age and race and ethnicity between 2016 and 2024. The solid line represents 0 to 4 years old. Dashed lines represent 5 to 19 years old. Dark blue lines represent non-Hispanic White, and teal lines represent non-Hispanic Black. Again, trends when looking within youth, age 19 and below, groups are consistent with the previous slides. Youngest age groups 0 to 4 report more frequently to the ED. Rates are highest among non-Hispanic Black populations, the teal lines represented here, of both age groups examined. More variation was observed in rates among non-Hispanic residents aged 4 and below. Next slide, please. So as Nancy highlighted in the previous slide deck, it's important that we're understanding the root causes of these disparities. There's some stark disparities and again, some discouraging trends that we're seeing now when we're examining data between 2016 and 2024. We're headed in the wrong direction. With that, we need to, understand, like I said, those root cause disparities to achieve health equity and really address these disparities. So when we're looking at root cause issues, it's equitable access to healthcare and asthma management and education and resources. It's addressing the environmental factors. So what we're doing within the Cook County Department of Public Health to advance this work is we're advancing something called the chronic disease, or something called the CCDPH's Building Healthier Communities 2030 Community Health Improvement Plan. This is our community health improvement plan for the local public health system. And so we've developed this plan in partnership with community partners, many of which are on the phone today or on today's webinar, and many others. And we've set specific chronic disease prevention and control goals, one of which is improving access to affordable and culturally appropriate healthcare and preventive care in historically marginalized communities to prevent and control chronic diseases like asthma. We also have a goal to improve access to safe, affordable, and inclusive infrastructure and programs that support physical activity, housing, quality, and climate resilience to prevent and reduce the burden of chronic diseases. Together over the next 5 years, we'll be continuing to work with our partners to advance these goals and implement key strategies to achieve these goals. So we look forward to staying connected with you all as we're advancing this work in suburban Cook County. We're also working to ensure equitable access to required staff trainings, on-site life-saving medication, and resources by supporting implementation of a previous act, the Stock Asthma Rescue Medication in schools across suburban Cook County schools. We've supported efforts around the Rescue Illinois plan, or program rather, of bringing these life-saving medication and resources to schools across our region. We also actively provide prescriptions and standing orders for schools that are not actively participating in the Rescue Illinois Act or program, so that schools have access to these medications. Reducing tobacco use and tobacco exposure among youth and young adults remain an ongoing priority for our unit and our department. We're advancing local tobacco-related policy systems and environmental change strategies. We're educating community-based healthcare staff in brief tobacco intervention and evidence-based cessation resources. We're bringing programming and vaping, anti-vaping presentations in partnership with Respiratory Health Association to school students across suburban Cook County. And we're exploring ways that we can expand CCDPH's existing programs to include an in-home asthma trigger assessment and connection to remediation services. And with that, then we're also partnering with other county departments. We're partnering with the Department of Environment and Sustainability to find ways to address historical injustices and promote more environmental equity by supporting advancement of something called the Cook County Environmental Justice Policy, really addressing the environmental issues and potentially triggers that are resulting in this disturbing data that we're reviewing. So with that, I'm going to hand it back over, and I think I'm going to hand it off to Dr. Patel from the Chicago Department of Public Health. My information's here. Feel free to put something in the chat if you have any questions. Thank you.
All right. Well, good morning, everyone. My name is Ajanta Patel, and I'm Medical Director of Chronic Disease Prevention and Health Promotion at the Chicago Department of Public Health. I'm going to pull up some slides, and I will just caveat that my goal was to show you all our asthma indicators and your ability to toggle through different views on our live health atlas. This morning, there are some server problems with the health atlas. So I've added some screenshots. We will go through those, and if we're able, we'll take a look at the atlas as well. So go ahead and share. And you should be seeing the slides. And I'll just put those in full. Okay. All right, so when we take a look at adult asthma across Chicago, we continue to see the highest burden of asthma cases on our north side of the city. Sometimes up to the highest rates are 14,000 per community area. But as we go down, as we kind of look at our indicators and we look at the adult asthma rate, so instead of looking at the total count of adults, the number of adults, we instead look at the rate of asthma compared to the total population of the area, then we see that the burden is disproportionately starting to move to the west and the south side of the city. So compared to the total population of our areas, the burden is higher on the west and south, where we see some areas as high as 27% of adults reporting that they are diagnosed with asthma. The total, for comparison, the overall rate of asthma amongst adults in Chicago is about 10.7%, plus or minus 0.7%, and that's using a combined 2023 and 2024 data. When we break that down by race, which you've heard about in other presentations already, we do see a higher burden of asthma in our Black non-Hispanic adults, and then second highest rate in our Hispanic or Latino adults compared to our white or Asian Pacific Islander adults in Chicago. The ED visit rate of asthma continues to be a higher burden on our west and south sides of Chicago. So these are per zip code, and this is going to roughly translate to Garfield Park, East Garfield Park. Some of these dark areas translate a little bit more to Englewood, West Englewood, and then we start to see some burden. I'm sorry, on our far south as well. I'm sorry, my screen actually the toggle bar covers the lowest part of the map for me, but hopefully you all can see that. So these are still adult data that you're looking at. So when you compare this view to the earlier view I showed you of the count of adults being highest on the north side, you actually see the burden of emergency department visits highest on our west and south sides. Demographically, which I don't have a way to show you this on a map, but demographically here in Chicago, our west and our south sides have higher percentages of Black and Hispanic Latino residents. It's a very similar geographical map when we look at youth asthma rates. So again, these are emergency department visits. So again, we see that higher proportion on the west and south sides. And then this is now you're looking at 2020 to 2024 data. So this is an aggregation of 5 years of data. This is an updated map of our data compared to what we had, I think, a couple of years ago. So there was a lag in receiving this breakdown of data from the state. Now that we have these, we're able to aggregate it over 4 years, and we have to do that in order to give enough data per community area that we can do this breakdown. Without this aggregation, we can still have those total numbers in Chicago, but we don't have enough data per community area to be able to report it at the zip code level. So we have to aggregate it across years in order to have enough data to show you this breakdown. But again, the ranges here are anywhere from 24 visits per 10,000 total residents up to 187 per residence. This is just that same breakdown with some of the zip codes marked out, so you can take a look at this. This data are available on the Atlas. When you're on the live Atlas, you can toggle over the zip codes, and the zip code number will pop up for you. We also have it available as a list, so you don't need me to necessarily give this to you in order to find that information. This is all publicly available to you. We're going to take a quick break from this and see if we can go over to the Atlas. We'll try our luck here. Okay, let's try. All right, so this is the chicagohealthatlas.org. If you type in Chicago Health Atlas into your browser, this will pop up. When you go to the home screen, I've already toggled over to the adult asthma rate, just in case things break down. But when you go to the home screen, there will be a search box, and you can just type in the word asthma, and you will see the indicators available to you. When you go to our Atlas, you're going to be able to do a lot more to toggle these views. So here we have the adult asthma rate 2016 to 2018, but you can do things like change the timeline and time period of the data. So you can go back and look at 2014 to 2016 data. You can come forward and look and do 2016 to 2018. You can sort of see that changing in the background there. So this is a really nice way to look and see how things are shifting over time. I'm going to show you a filter on a different view, but I'll move that back to the 2016. When we go to count of adult asthma, which was the first map that I showed you, again, we have that as recently as 2023. So you can go back in time to 2020 if you like. And again, we have a lot of gaps because of suppression of data. And you can also look at, if you want to see more richness, you can combine data across 3 years, and then you'll see some of that data filling out. When we look at the youth ED visits, to show you some nice features that you can use on the Atlas to explore include these filter tabs. So with our new addition of a filter, you can add in a sort of a cross-examination of asthma, as well as any of our other indicators on our Atlas. So for example, one of the things I looked at was an index called the Area Deprivation Index, which is a marker of socioeconomic status and access to resources across the area. You can click on that eye to learn more. This is an index, so it's a combination of domains around income, education, employment, and housing quality. When we look at this score, and then we look at this map, this is going to be the full spectrum that you're looking here is the full spectrum. So, this is going to still be viewed with all of the community areas. But once you start to move, and I'm going to move it down for a lower score. I'm sorry, this is deprivation. So this one goes the other way. So a higher score is greater deprivation. As you move, you can see that when we start to hit areas that are at 40% of the area deprivation index or a score of 40 or greater of area deprivation index, that you start to see certain areas retain. And so these are going to be areas that have an area deprivation index of 40 or greater now. And you can see that we continue to see that that overlaps with where we have the highest rates of youth ED visits. Some of the other things that you can take a look at, if we looked at, I have this on the end, but I wanted to show you for rent burdened housing. And this is where we will be able to look at the percent of homes that are occupied by renting families. And so again, as we start to move up and we look at communities that have higher percentages of rental homes, we can start to see that again, the areas that retain. So now we're looking at more than 40% of homes are rented units. These continue to be the areas with the highest percentages of asthma in youth. There are many other things that you can look at here. We don't have we don't have maybe everything that you might want to see, but there are certainly a lot of different ways that you can crosshatch this data. I also took a look at crowded housing. So again, you want to close out some of the other filters just to get that view. But when we toggle through here and the percent of homes in that zip code that are reported to be crowded, again, you can kind of see that and this one was interesting because it isn't a perfect trend with our areas with high asthma, but you still see on the west side that this indicator has a lot of overlap with our asthma burden on the west side, more so than it does on the south side. It appears to be an indicator of housing need and asthma need on the west side of Chicago. And so when you type in asthma in our atlas, you'll see that count of adult asthma, the adult asthma rate, the asthma ED visit rate for adults, and the count of ED visit rates for adults. And then as recently as the last 2 years of data report, the 2 cycles of data reporting, we are now reporting on the atlas the youth asthma ED visits and ED visit rates. So this is not something that we had in past years. This is new. So we're excited to be able to have that on here so you can look at these data yourselves and you can do this sort of examination yourself. Again, we don't have all past years, but we do have going back to this aggregation of 2019 to 2023 and an aggregation of 2020 to 2024. I did want to show you that the data don't look remarkably different between 2019 to 2023, that first window, and this second window. Again, it's only, moving it up a total of 1 year, but we don't see a lot of difference. I'll show you this one. So you can see again, kind of the burden of areas. This is 60623. This is 60651, 60615, 60620. You can kind of see these areas highlighted here. If we move up 1 year, you still see essentially the same areas highlighted. So it's not going to be a big shift on any 1 year, but I do think this is a great tool for folks to sort of explore, and you can take a look at this on your own time. So I'll go back to my slides. I'll make sure I'm sharing the same thing. Okay, so with that, again, some of the highlights is the numbers of adults reporting the diagnosis of asthma are highest on the north side of the city, but we continue to see the top areas of ED visits in both pediatrics and adults on the west side, south side, and far south of the city. This is really unchanged from the 2019 to 2023 window. We are now in the 2020 to 2024 window of data. And then the geographic patterns trend with that area deprivation index. Low median income also trends with these ER visit data, as well as the percent of homes rented, which is rent burdened, the indicator I showed you of rent burdened community areas. So I wanted to talk a little bit, we already saw this, I want to talk a little bit more about the concept of housing in Chicago's asthma, as we look at Chicago asthma burden. So taking a more static look at this, when we start to approach 40% of units or greater are occupied by renters, you can see a really clear alignment with our areas of high youth asthma ED visit. Many of us are familiar with the struggles of families who rent homes. Here in Chicago, we have quite a high, uh, uh, quite a large market for rental homes. And many of us who care for kids with asthma are familiar with stories about the home maybe not being in the best shape. And we've explored use of tools like legal aid, letters to the landlord, et cetera, to try and address these. So this is one indicator that we have on our atlas that takes a look at issues related to housing. But one of the things we've been doing at the health department over the last few years is trying to understand more about housing and asthma. So again, the 10,000-foot view of Chicago homes is we do have obviously a variety of housing and architecture styles across Chicago, but one thing that we see in a lot of our neighborhoods across the West and the South is these smaller homes that are either one single family, 2 to 3 family homes. We have a lot of different areas and types of housing, but one of our features is that we have smaller units. We do not have large high rises, dominating our south and west sides. Instead, we have a lot of older homes and smaller 1, 2, or 3 family homes. And what this means is that if you are a landlord in these areas, we have a lot of landlords essentially, and that can create quite a wide disparity of the way that the houses are taken care of. We see a lot of dilapidated housing. We see a lot of historic housing that has, been maintained in various states of repair. And then we also have the same feature, even if we're not looking at rental homes, we have the same features for owner-occupied housing, that we still have historic homes. We have these aging areas, and we have, again, densely populated areas of the city. So this is really what Chicago looks like. And so when we think about housing related to asthma, I keep this in mind because this is what our families are going through. They're working with independent landlords. They're working with historic homes that they have to repair, and it can be quite pricey when they think about trying to make modifications or repairing those homes. We took a look several years ago at a crosshatch of asthma data for adults as well as old homes. So this is buildings built before 1979. And if you look at this heat map in yellow, you will see areas that are considered to have high asthma burden, and blue, you will see areas that have old homes, and black is where they intersect. So particularly on the south side of the city is where we have both old homes and homes that are high with an asthma burden. And so old homes have really become a point of interest for us when we think about asthma. Why are old homes very frequently seen as unhealthier homes? And there are several contributors to this, but it sort of summarizes in 2 main ways. One is that older homes are more likely to have structural damage. Over time, there can be leaks and cracks, and so you can get mold development anywhere that there's leaks in roofing or walls or in structures. And then you can also have pests enter through cracks. So structural damage can lead to issues with roofing, walls, flooring, and pipes. The other problem with older homes is that there may be a lack of maintenance over time. So again, you have older features, but it would take a very longitudinal process of maintenance in order to keep everything up to date. So you will have older plumbing, you will have outdated and broken systems, including heating and cooling systems. And those in and of themselves can be inefficient. They can grow mildew or mold. They can be combusting in different, in outdated ways and contributing more to the indoor air pollution of the home. And then you can also have issues with the family maybe not being able to afford updates to it and using other sources of heating or cooling if they don't have ways to keep up their home. So essentially what we see in Chicago is old homes and damaged homes becoming unmaintained or dilapidated homes, and this lower cost housing tends to shift its burden over to our poorer residents and our renters of low cost housing. So we've moved this forward. We've been taking a look at the principles of healthy homes. So this is a series of 8 principles as maintained by HUD. There are some other lists that take it a little bit further in terms of sustainability of homes, but the key principles of a healthy home include keeping the home dry, keeping the home clean, keeping it safe, keeping it well ventilated, keeping it pest free. So you see rodents and cockroaches here. Keeping it contaminant free. This actually has a lot more to do with things like radon, lead, other compounds, asbestos, and keeping it contaminant free. I'm sorry, keep that contaminant free, keeping it maintained, and keeping it thermally controlled. That includes heat and cold. We know that these, as you read these, you can probably hear resonance with your experience working with families who have kids with asthma. So how do they overlap? Healthy homes and asthma overlap, particularly in regards to keeping the homes clean and removal of dust particles and dust mites. Keeping them dry is a huge feature of a healthy home in asthma. We really want to remove sources of mold, mildew, and that includes areas that are persistently damp. Keeping them pest-free, so avoiding roaches and mice in particular because of the dander and the dander that they shed that contributes to that is an asthma hazard and can trigger asthma in many people. And then keeping them well ventilated and removing airborne particles. With ventilation, the principle of healthy homes says well ventilated. Functionally, for patients with asthma, this is really about filtration. Because ventilation, yes, it is important to have a ventilated home, meaning that the air can flow between the outside environment and the inside environment. But because this is Chicago, we do have an outdoor pollution burden as well as an indoor air pollution concern. So in addition to having a ventilation component of the home, meaning can air flow inside to outside properly, we also want to make sure that air filtration is well maintained so that those particles can be removed from the indoor environment. And then thermally controlled is making sure that the house is safely heated and cooled. In Chicago, we do have homes that are not heated and cooled through, a well-maintained heating system, and families will turn to things like burning wood fuels, diesel fuels, kerosene, using their ovens and fireplaces in order to stay warm in winter. So when we looked at our areas of top concern for asthma burden and where there could be improvements to housing, we do target our areas on the south side, as well as a little bit on the west side. Again, because of what we shared around older homes and rates of asthma. So many of you have already heard our backstory about developing a home remediation program. So I'm not sure at what last time I was able to tell the CAC about it, but we did receive a grant award from HUD, which is the Federal Department of Housing Urban Development. We were formally awarded that in May. It is a $2 million award over 42 months, which is 3.5 years. The way we plan to use this grant is targeting 74 homes for pediatric asthma home remediation. And in pilot, we've been in discussion with the Southside Pediatric Asthma Center, who we want to thank so graciously for working with us on this, again, because of their geographic location on the south side. And the way we're piloting this is an eligibility model where we want to have referrals from children who have moderate to severe asthma in at least one child. We would also be able to accept multiple children afflicted with asthma from one family, and also a reasonable to high suspicion that a structural home trigger is the burden for their asthma. So a reasonable to high suspicion that there is a mold issue in the home, or an ongoing pest issue in the home, or a poor air filtration, or some other component of the structural home that may be triggering their asthma. There is an income eligibility in order to have a home repaired using HUD dollars. CDPH will be taking a look at that. So that's not for the referral. That isn't something the referring agent needs to consider. You can consider it for sure, but we will have to formally evaluate their application packet to ensure that they qualify. Our strong preference is to have referrals from those who've had a home visit or a home evaluation at the very least completed, so that the referring person has knowledge of the possible structural hazard and can speak to that with our team. Whether they have witnessed or have through their evaluation have strong reason to believe that there's mold or dampness, and they could talk about the location of that, knowledge of dust or pet and pest burden. Now, that being said, our inspectors will be going out to do a full Healthy Homes evaluation, so they will see it themselves. But we do believe that in order to really treat children and families who have this burden in their home, that we would prefer, as we get started, to have referrals from those of you who have knowledge of that in the home, a strong suspicion. And then we also are strongly requesting that referrals are made for families who have demonstrated a response either to home visits or, otherwise are highly responsive to engagement. And there's a strong reason to believe that they will complete the forms and answer the phone. And that's just in order to make sure that we're, marching forward and utilizing our times and services appropriately. So the way the process will work is a referring community health worker, asthma educator, or other provider will complete a red cap referral form. So in pilot, this has already been shared with Southside Pediatric Asthma Center. We're trialing it right now with our first two referrals. And then a CDPH coordinator. Currently, this role is being filled by Julia Myers within our Healthy Homes and Lead team. We'll offer up to 3 callbacks. And if those are unsuccessful, she'll connect with the referring provider to see if we can get the family on the call. Once they've connected, the family's going to receive a full application for HUD eligibility. They'll also receive an asthma questionnaire. So the HUD grant is not screening for asthma. CDPH will be asking those questions, and so it's going to be a HUD application for eligibility as well as an asthma questionnaire that includes the family's sort of attestation about the concerns they have about their home, and then they'll complete that and return it to CDPH. CDPH will complete the income eligibility on the back end, and if they are eligible, an inspector will visit the home and potentially connect, if needed, with the referring provider for more information, which may or may not be needed. And then SSPAC and CDPH are also trialing in this process, looking at a need for quarterly case reviews or touch bases between the teams. So if that is fruitful, we would continue that with any other referring partners. And within 1 year or after 1 year of the repairs, we're aiming for a follow-up survey for families. I think I present on this so much that sometimes I forget, but essentially the repairs that we're targeting are the things I've spoken about, which are visible mold, visible dampness, visible areas of leak. So that could be, seepage through walls. It could be pipes leaking, but anything that is a concern for persistent leak and concern for mildew or mold, or visible mildew or mold. So that's that category. And then the other category is going to be air filtration. So trying to prioritize air filtration, making sure that HVAC is up to date, and then other contributors to dust burden that can be managed through structural repair include removing carpet, replacing that with hardwood flooring or hard flooring, potentially vinyl flooring, and then we'll sort of see how it goes in terms of replacing curtains with blinds or other elements. I am not confident if HUD can do duct cleaning, but that is something that has come up. So we're really going to be trying to target those areas of asthma hazard. I believe that is my last slide. I just have a thank you slide. And so I'll end there. Thank you. And I believe
Yes,
Christina.
Thanks, Dr. Patel. I am up next. Great. Thank you, Rochelle. All right, good morning, everyone. I appreciate the opportunity to present today on The recently enacted Federal Budget Reconciliation Law, or H.R. 1, also called the One Big Beautiful Bill Act, and the sweeping cuts and new barriers to healthcare access it imposes. Today, we'll explore what H.R. 1 means for Illinois, who will be most affected, and why our voices are critical in the fight to protect Medicaid, because we know that this program is not simply a line item in a budget. It is a lifeline for millions of people nationwide, including some of those with asthma in our state. Next slide, please. Medicaid is a cornerstone of healthcare in Illinois, covering more than 3.4 million children and adults, about 1/4 of the state's population. In 2023 alone, Illinois received $21 billion in federal Medicaid funding. According to Healthcare and Family Services, or HFS, the state agency that oversees Illinois Medicaid, Medicaid accounts for over 17% of the state's general budget. Beyond healthcare, Medicaid is also the third largest source of funding for K through 12 schools in Illinois. Among adults ages 19 to 64 who are enrolled in Medicaid and are not disabled, caregiving, or in school, 68% are employed. This highlights that the program primarily supports working individuals and families who still need access to affordable health coverage. Next slide, please. H.R. 1 was enacted on July 4th, 2025. It's the biggest and most harmful cut in Medicaid history. It slashes over $990 billion for Medicaid over the next decade. It'll eliminate healthcare coverage for 10 million people by 2034, and an additional 4 million people will lose coverage if the enhanced tax credits that make healthcare more affordable for millions of people are not extended. And nearly 1 million people will lose coverage due to Centers for Medicare and Medicaid Services, or CMS, rule that was finalized this past June. Next slide, please. So this is a high-level overview of some of the biggest Medicaid impacts in H.R. 1. The law will alter eligibility rules. It will fundamentally change how states finance Medicaid and make other cuts, including restricting eligibility for immigrants and imposing mandatory cost sharing for patients. Under H.R. 1, it'll be more difficult to qualify for Medicaid and harder for current employees to keep their coverage. For example, states will be required to redetermine eligibility for coverage every 6 months rather than annually for expansion enrollees. This means that people will lose access to coverage not because they're ineligible, but because it doubles the administrative burden from once to twice a year. H.R. 1 also cuts retroactive eligibility from 3 months to 1 month for expansion enrollees and to 2 months for non-expansion enrollees. Retroactive coverage allows eligible patients to get covered for medical services that were received before the date of their application, and it's a critical safeguard for those who experience a sudden health event. H.R. 1 also places a 10-year moratorium on two rules that were finalized under the Biden administration that would streamline eligibility and enrollment. These are also significant changes to Medicaid financing. One of them limits states' ability to fund its share of the Medicaid program. For example, all states except Alaska fund some of their Medicaid program through taxes on healthcare providers. These taxes have also been critical to funding Medicaid expansion. In some states, H.R. 1 would provide new or increased provider taxes. H.R. 1 also places new caps on state-directed payments, or SDPs, which are often used to bolster provider participation in Medicaid. So with less ability to use these provider taxes and SDPs, this will place pressure on state budgets to find alternative funding or cut back on payments and services. And finally, H.R. 1 restricts Medicaid eligibility for immigrants and requires cost sharing of up to $35 for some services, which may discourage people from seeking services at all. Again, the big picture here is that H.R. 1 cuts Medicaid eligibility, makes it more difficult for states to fund their Medicaid programs, and makes it more difficult for people to access needed care. Next slide, please. One of the most impactful provisions of HR 1 is work reporting requirements, which states are required to impose by December 31st of next year. These requirements could result in an estimated 5 to 7 million people losing coverage by 2034 nationwide. The provision requires states to make Medicaid eligibility for adults in the Affordable Care Act or ACA expansion category, those ages 19 to 64, conditional on reporting at least 80 hours per month of paid work, community service, or education. If an individual is denied or disenrolled from Medicaid because they do not meet these work reporting requirements, they would also lose eligibility for subsidized coverage through the ACA marketplace. States must establish processes that rely on existing reliable data sources. The Secretary of Health and Human Services is directed to issue implementation guidance to states by June 1st of 2026. States must begin reaching out to enrollees between June and August of next year. Additionally, states that demonstrate a good faith effort to meet these requirements may request extensions, which could be granted until December 31st, 2028. So there are some exemptions to work reporting requirements, including for pregnant people, people with disabilities, and medically frail individuals. Next slide, please. HR 1 also includes funding for the Rural Health Transformation Program. Over 5 years, from 2026 to 2030, $50 billion in grants will be available to states. Half of that funding will be split equally among states with approved applications, and the other half will be distributed based on CMS discretion. The program focuses on 5 key goals: improving rural health outcomes, ensuring sustainable access to care, building a strong healthcare workforce, fostering innovative care models, and advancing technology solutions. Next slide, please. Here's an overview of the implementation dates for key Medicaid provisions in HR 1. The implementation will happen in 4 major waves, as shown here. To call out a few of the most impactful provisions, the CMS is required to provide guidance on how states implement work reporting requirements by June 1st of 2026. These requirements will take effect December 31st of 2026, as will those 6-month redeterminations. On January 1st, 2027 is when the reduced retroactive coverage will take effect, and the new cost sharing requirements will take effect on October 1st, 2028. Next slide, please. So as I highlighted earlier, HR 1 restricts states' ability to leverage tools like provider taxes and state-directed payments, winding them down over time. These financing tools have allowed states to fund Medicaid expansion, increase access to behavioral health and home and community-based services, and support safety net and rural hospitals. These and other cuts will force states like Illinois to cut eligibility or reduce benefits for workers with low incomes, children, older adults, and people with disabilities. Illinois will be especially hard hit by all the Medicaid cuts in this law, losing an estimated $34 to $57 billion in federal Medicaid over the next decade. Next slide, please. The work reporting requirements provision requires patients to repeatedly justify their enrollment in work or another qualifying activity at a minimum of twice a year. These initial and ongoing requirements create navigational burdens that would deter people from seeking coverage at all and put at least 257,000 people in Illinois at risk of losing Medicaid coverage under these requirements. Work reporting requirements have serious operational challenges that states are ill-prepared to address, especially under the expedited timeline required by HR 1. States will face enormous administrative costs to track work activities, train staff, and put a system in place to identify and track exemptions. For example, a Government Accountability Office study of work reporting requirements estimated that the administrative costs for just one state could be up to $272 million. HR 1 also increases the frequency of eligibility checks for Medicaid expansion population, which includes about 843,000 people in Illinois, Again, increasing opportunities for administrative errors to remove eligible individuals from coverage. The evidence is clear that shorter redetermination periods cause coverage disruptions for people on Medicaid. The additional bureaucracy will burden state budgets, increase churn as people incorrectly lose coverage, reapply, and then are reinstated. The administrative cost of churn is estimated to be between $400 to $600 per person. Next slide, please. The Lung Association and health partners throughout Illinois, throughout the country, are deeply concerned about HR 1 and its far-reaching implications for the Medicaid program. The provisions in HR 1 ranging from increased cost sharing and work reporting requirements to restrictions on eligibility and enrollment threaten to undermine access to care, increase financial burdens, and worsen health outcomes for vulnerable populations, including those with asthma. So as we move forward, here are some action steps that you can join in with us on. First is listening to patients and hearing firsthand how these cuts impact their lives and sharing those stories with their permission. I've included one way for you to share stories via the QR code on the screen. Additionally, the Lung Association will collaborate with partners to provide information on lung disease and exemptions to ensure vulnerable populations are protected. We'll also analyze state legislative and administrative proposals aiming to address shortfalls caused by HR 1 and provide recommendations. And finally, we will share more Illinois-specific background information with advocates and decision makers as we continue to understand the implications of HR 1. Next slide, please. So in closing, the Lung Association remains steadfast in supporting Illinois families as they face the challenges this legislation poses to accessing quality, affordable health care. While the passage of HR 1 is a serious setback for public health nationwide, your voice is more important than ever. I've shared a QR code here for you to engage with our advocacy. We must speak up, we must share impactful stories, and urge our state lawmakers to protect Medicaid so that we can reduce the harmful impact of HR 1 on healthcare access as much as possible. Thank you. I'll turn it back over to Dr. Volerman.
Thank you very much. Wow. So much good information covered. I feel like I was jotting notes the whole time and kind of taking stock. It's awesome to see all of the updated data. And Christina, fabulous to hear from you about kind of the implications of national policy locally. There's a few questions that I saw across the chat. And if folks have other questions, please feel free to kind of add to the chat and or raise your hand. I think kind of to start, and these questions will go in order as kind of how they came about. So first, there was some discussion, particularly in the state level data and the Cook County data, that talked about kind of variation in terms of what was seen in as related to asthma-related emergency department visits, and differences seen in the county versus what was being seen statewide. And so kind of some questions raised as to theories about why emergency department visits have increased. Interested in terms of Amy and Nancy, kind of hearing your thoughts on what might be driving these the higher ED visits at the county level and what might be driving differences between the county and the state levels.
Yeah. So just to speak to some of the county level data that we're seeing, so I think some of this speaks to utilization of healthcare post-pandemic. So we have seen over the course of the years and non put in the chat for medical care utilization across the board, all cases, not just asthma, has increased since 2020 in suburban Cook County. Um, so I think this kind of speaks to a couple of things. It's healthcare utilization as a whole, but then also access to healthcare. I think Mark brought up, a point regarding accessing, a primary care physician or, your medical doctor, and perhaps resulting in a lack of access, resulting in ED. Visits, higher ED visits. So that's something to consider. I think, we do see geographic shifts of populations as well. That's not something we looked at within this period of time, but, we are seeing shifts in populations from city to county, and, resources do not follow individuals necessarily, and accessing those resources. There's, physician deserts in the south and west suburbs as well. So as a result, going to the ED is where you're receiving care. So there's a variety of different, it's how are we, what type of healthcare access is there, and how are we utilizing, healthcare in general post pandemic. So yeah, I'll pause there to see if there's any other thoughts, comments.
I think you nailed that one, Amy. I don't have anything to add.
And I think that this just ties to another point too regarding, housing stock and quality of housing stock. Agenta, thank you so much for walking us through the all of the variety of data on the Chicago Health Atlas. I will say that working with non-NR EPI unit, we pulled together this more current data. All of this data at some point in the near future will be on the Cook County Health Atlas as well, and we'll drop in the chat a link to the Cook County Health Atlas. There is an indicator on the Cook County Health Atlas connected to housing age as well. So looking to make some similar maps to the maps that Agenta presented on kind of ED utilization related to asthma, and then, age of housing, housing burden, quality of housing, to help make those connections. So just wanted to call that out. Information, this data will be made available on the Cook County Health Atlas. We'll drop it in the chat. It's not currently there. This was just newer data.
Awesome. Thank you, Amy, and thanks, Nancy. I think the next question kind of, and I know, Ajanta, you shared a little bit more about the pilot through the home remediation program, but would, want to create a little bit of space for you to kind of share the timeline of the pilot, and, really, the goal is to kind of address structural factors that are driving, both asthma, but also other health conditions that we know are affected by the home environment. And so would love to hear more about, what is kind of the timeline, what are the different parts of the program? Are there aspects that go along with the home remediation? And, for those of us that are thinking about kind of, beyond the pilot, in an ideal world, what would it look like to kind of scale this or to expand this? And what outcomes are you looking for in the pilot to consider that?
Yeah, thanks so much. So we developed this in consortium with our lead partners. So HUD funding is historically pretty strong for lead remediation. So as a city office, we do have contracts with HUD to remediate homes for lead. And in the city of Chicago, as I'm assuming pretty much everywhere, there are ordinances, and it's legal. We are legally bound to remediating lead. And so that incentivizes strong program architecture to ensure that we have inspectors who can go to the home. We have administrative processes to process people's applications, and that we have contracts in place with housing contractors who can do the remediation. So what we learned in just over the course of the years that we've been partnering with them is that this is why we focus on old homes. Lead burdened homes are also old homes. And I didn't show the data. I think I've shown it in this forum in previous years. But when we started doing this exercise, we just did a scatter plot of community or zip codes with high lead burden So children age 1, 2, and 3 are routinely tested in Chicago for lead. And when we look at a scatter plot of where there are community areas with high lead burden and where the community areas with high asthma burden, it's a nice, that graph trends. And it's because of the houses. And so it makes, administratively, it helps us to work with the lead program to do this because the contractors are already in place. We do not have to duplicate those contracts. It also means that a lot of the processes, like just reviewing a HUD contract, a HUD application to make sure that the family meets 80% of the average median income of the area, that application, when we get those applications for our lead program, they are routed through a third-party contractor who runs their software to see if the family meets eligibility criteria. We don't have to rebuild that process. We can literally do the same thing for a family going through this. I will say, one of the things that we're working through is that the grant that we received from HUD is not an asthma grant. It's a healthy homes production grant. So it is an innovation grant to achieve goals in healthy homes. And so we are making it about asthma. We are making it about kids' asthma because kids' asthma is important to me. And so we are making it about kids' asthma. But to that end, the target goals for HUD are not about asthma. We are not expected to report health outcomes of asthma to HUD. And so what we've really wanted to do is streamline this. And so it's been very iterative, trying to understand how do we work with partners to make sure that we can do this in a streamlined way. The Chicago Department of Public Health is not a clinical element, like we're not a clinical agency. We don't have the tools. We haven't had them in lead also to really do a health assessment about somebody's asthma. We think it would be an increased burden on families to make them turn in medical records, and we don't really have any reason or authority to review those medical records. So instead, we are taking it on good faith, and we think that piloting this through people like community health workers or asthma educators who've been to the home, who've talked to the family, who've seen it with their eyes, who know that this family is willing and able and they've had that human interaction with them. They're like, this family is going to see this through if they're eligible. We think that that's probably a more successful way for us to start when we really are scaling to 7 or 8 homes a quarter, so a couple a month. And so we're not trying to achieve, hundreds of referrals. And so we think that this will be a good way for us to target families that are continuing to show up in places where they're looking for asthma care. And the reason they continue to show up is that there's something that is never going to get solved, and it's their home. So if they have mold in their home, they have increased dust and pest dander burden in their home, even if it's pet dander burden. Some people I saw a presentation this year at the American Thoracic Society meeting where I go, someone presenting the data about how much pets help with people's, behavioral health. And so this was in an asthma forum suggesting that we have to help people find workarounds to accommodate their pets, which I thought was a really interesting thing to present in an asthma forum. But no matter what is driving their asthma, if there's a strong belief that there's something in the home, we want to help. So as we pilot, what we're really trying to do is make sure that our processes work for the rest of you. So checking out, does the red cap work well? Are we getting the notifications properly? We're really operating this on kind of a thin layer of staff. So we had an epidemiology fellow who built the red caps for us. And Julia will process those. So we want to make sure that it works well for both teams so that we're not making ridiculous undue asks of a team in order to make a referral. And that, they're not feeling challenged to have to scurry around to gather data that's, it would just present a burden for them to be able to gather that data. But at the same time, we have enough information to be able to do a targeted approach. For those of you who have ever done a housing repair, like whether your own homes or you've ever thought about this, it's not cheap. So the amount of money we have for 74 homes equates to about $11,000 per home, which is not a ton. It's not a lot to do structural repairs. The city is prepared to match a little bit of funding with some bond funding that was released in the pandemic for healthy homes, but that is a second layer of funds. And so for another program looking to do something like this, I know Amy's expressed interest from the county, just keeping in mind that you really, if you want to do right by the asthma hazard, you're going to have to target. We've talked to programs in Wisconsin, New York, LA, that are trying to do this through government funds, and none of them have extravagant budgets. It's all pretty pretty tight budgets. And so really trying to be thoughtful about how we can target those impacts for kids, and how we get that information in a succinct timeline. We do want to open this up to other groups, especially those who are working with community health workers and asthma educators that visit homes. That's absolutely our goal in Chicago. Whether or not we would open this to like all clinicians, I think is still sort of a gamble, because then, how would we manage those relationships? We're not sure yet, but we definitely want to open this up to other groups that have community health workers and asthma educators in the field, because we think those people are best positioned to be able to tell us what they see and communicate and liaise on behalf of the family. And I addressed like some of the pilot timeline. What we had set up with HUD was what we would do. We got the funding in May, and then I think the first quarter it was like 0 homes. The second quarter was 1 home, and then I think from there we're supposed to be scaling up to 7 or 8.
Fabulous. Appreciate the deep dedications. For those of us that have done various programs and interventions, the structural factors are always the hardest to influence, and we all want to, but it is really challenging. So applaud you on pushing this forward. I am going to wrap up our discussion here, just to attempt to not be the person that is pushing us off entirely off the timeline for the conference today. So a huge thank you to Nancy, Amy, Ajanta, and Christina for their really incredible data and thoughtful contributions today. And we will take a 5-minute break and regroup at 11:39. Um, Thank you all.
Good afternoon and welcome back to the Chicago Asthma Consortium Fall Conference. I am Dr. Renee Matthews and I'm a board member, but I'm also going to be moderating this panel with Dr. Sharmali Noyes, Matt Seymour, and Gloria Seals. And so, panelists, are you ready?
Yep.
I'm ready.
Okay, perfect. Dr. Sharmali is an esteemed physician at the University of Chicago Medicine, where she holds the position of Associate Professor of Pediatrics and Medicine, specializing in allergy and immunology with a particular focus on pediatric allergy and immunology. And Matt Seymour is the Executive Director of Mobile Care Chicago for 20 years. Mobile Care has used asthma vans to provide allergy and asthma care to over 13,000 children at no cost. Gloria Seals is Sinai Urban Health Institute's Community Health Work Manager. She joined Sinai Urban Health Institute in 2000 as their first community health worker, specializing in asthma education and management. So first we will have Dr. Sharmali, and I don't believe you have any slides, so we're just going to have a conversation.
I do have some slides.
You do? Okay.
But yeah,
That's fine.
that's okay.
Yep, that's fine.
Okay. Just give me a moment.
And just like before, if you have any questions, please put them in the chat box and we will try to address those at the end. Thank you so much.
Are you guys seeing the right one or did I swap it
You
wrong?
got it.
Okay.
I think so. Navigating the current landscape.
Yeah. Okay, but you don't see my notes. Okay, presenter view. Okay. So, again, thank you for that introduction, Renee. Um, the first part of today kind of was talking about what the current landscape is, and I think we were just wanting to discuss a little bit about how we're navigating it. As Renee had said, I'm a allergist immunologist, and I see kind of across the spectrum, both kids and adults with asthma. And also, I'm the clinical director of the Southside Pediatric Asthma Center, which you heard about some of the great work that is being done with CDPH. So I'm not going to go into this too much because the previous speakers, Christina and others, really talked a bit more in detail about the impacts of Medicaid, Medicare cuts. But just briefly, just wanted to highlight again who this really is impacting. Not that it isn't going to impact everyone, but primarily, one of the hardest hit people are going to be those with low income adults aged 18 to 64 without young children, and also older adults with changes in the Medicare marketplace as well. And how is that really going to impact is that it's going to definitely reduce access to care, and it's really gonna, these cuts are raising a lot of financial pressure on health facilities, including the large universities that we have, university health systems that we have here in Chicago, and that may lead to, hospital closures, as well as, healthcare services facilities that primarily care for patients that are in low income areas may have to cut back on services. And then also based on past experiences, some of fewer providers also will likely accept Medicaid. So how are we managing that? Again, I know the Southside Pediatric Asthma Center was discussed, but this is a program that is powered by the health system of U Chicago Medicine. And what that is the real vision is to really reduce the burden of asthma for children and families on the south side of Chicago. And much of that is done by education, community health workers who go into the home, or also not necessarily go into the home, and help families get access to asthma specialists, access to transportation so they can come to their appointments, and a lot of other connection to social needs, and also providing education and about asthma and medications used. And also we have asthma resources on the Southside Kids Asthma.org website.
Um, so, one of the things that I feel like I have been doing more and more is referring to the Southside Pediatric Asthma Center for children that are coming into the hospital or even emergency room as well as clinical setting, so they can get access to a lot of these to all these resources, and also additionally the pilot study that was mentioned earlier. I'm going to skip these. Also, other ways to think about too is to help reduce the issues with access. Is also thinking about doing telemedicine more. That was something that we leaned into a lot during COVID, but now, but now also leaning in again into it when patients are having more difficult time getting access to actually coming to the appointments, or because I think it was mentioned in the chat earlier, like the wait time can be long for in-person visits, but sometimes we can get people in quicker via telemedicine visits. Obviously, it depends on what the situation or concerns are, but that's one way. Another web-based way too is the Project Echo Asthma, which is housed here at U Chicago. But what it does is it's actually trying to educate community providers in areas where there are vulnerable populations on asthma best practices. So again, if there is reduced access to care, let's say coming to Hyde Park or coming to, even the Chicago, to downtown Chicago, trying to get providers that are out in the community, again, those that are really providing care to vulnerable populations. So they are getting quality care, quality asthma care. Additionally, too, when I think of access to care, I also think about access to pharmacies. And so this was actually some data that was looked at by using U.S. Census Bureau data, but this was actually visualized by NPR WBEZ, and they actually looked that particularly in the south and west sides, there's a lot fewer CVS pharmacies compared to the north neighborhoods here in Chicago. And additionally, they also found that the closest Walgreens to you may actually serve many more people or patients than those in the north neighborhood. So again, just looking at access to not only healthcare services but also pharmacy services. That's something that there are disparities there. And this is a paper that we recently published earlier this year, and I know it's really small, so I'll just kind of highlight the top things. Is really one of the things that we found is that having if your closest pharmacy is further away, then that was associated with greater exacerbations. Some of the other things we found that were protective were like tree crown density and green space. So one of the other things to think about as far as policies to again help reduce these gaps, I'm not sure exactly where this is, but about a year ago, the Illinois House passed this bill capping monthly inhaler costs at $25, and this has been signed and is supposed to be implemented is anticipated to be implemented next in 2026. So other resources that I have been sending that I utilize for my patients, especially my asthma patients, are, and I think this was mentioned earlier, are connection to organizations such as MTO, Metropolitan Tenants Organization, for to help navigate communications with between the landlord and the tenants, and also thinking about potentially helping with repairs. And then also, again, a lot of our a lot of patients too with asthma, we know that there's a higher risk of mental health diseases in patients with chronic disease, particularly asthma. So there are resources through CDPH and others to provide mental health services. And then, yeah, and then there's this warm line is another one. And then I just have a couple more slides just to talk about a little bit about the impact of NIH funding. I know it was discussed earlier about the Medicaid and Medicare funding, but first of all, I just, as a researcher as well, thinking about first of all, what does NIH funding provide? Not only obviously for the research it supports, but also wanting to think about every dollar that is provided by the NIH actually results in about $2.50 return to the local community in which the research is taking place. And NIH itself funding helps support more than 400,000 jobs at medical centers across the US in every single state. And the NIH also helps support the training of physicians and researchers. You can see the stat here. And also federally funded research also helps US science-based startup companies annually, over 1,000. And so what has some of the impacts of NIH, what are the positive impacts of NIH funding had in the space of allergy, asthma, immunology? So NIH funding has enabled biologic therapies for asthma, also looking at breakthroughs in food allergy, immunotherapy and prevention, improved eczema treatments, better care for immune deficiencies, as well as training for the next generation of asthma specialists, as I mentioned, and also access to innovative treatment. And so the concern is without this NIH funding, clinical trials will stall, we will have fewer breakthroughs in medicine, and also have fewer asthma specialists be trained, and particularly in rural and underserved areas. So just briefly too, what is some of the impact of terminated research funding? So between February 28th and April 8th of this year, almost 700 grants were terminated across the 24 of the 26 institutes and centers. The two that had the highest number were NIMH, the National Institute of Mental Health, and the National Institute of Minority Health and Health Disparities. But also interestingly, the National Institute of Allergy and Infectious Disease, as well as NIMHD, accounted for the most, they had the greatest amount of funding terminated. And so lastly, the NIH grant terminations actually disrupted almost 4% of active clinical trials. So patients that were currently enrolled in active clinical trials had to be completely, the clinical trials had to be completely stopped, including those treatments. And it affected almost 75,000 participants and resulted in $1.8 billion in funding loss. So, so some of the things, again, as a physician scientist, that can be done, and I think somebody else mentioned this, is really telling stories about the benefits of these clinical trials and research in general, and I think just in general, expressing as researchers, expressing and concerned citizens that cuts in the NIH budget are going to have a catastrophic impact on the lives of our patients, communities, and our country. So, some of the things that I know I have done is also think about other grant funding opportunities. So Grant Forward is a website that can be utilized to look at potential grants that may be available to you. Other things obviously are looking still at grants.gov to see, what there's these other key funders that can provide, but they have become very, very competitive now, as you can imagine. I know I was speaking to one foundation where they usually get, they fund 2 grants and get, maybe 150 applications. Now they have received over twice that amount, over 400 applications just for 2. So those are even more competitive than the NIH grants. Other things too, looking at if you are at an institution, there may be some institutional funding, but again, that may be limited. And then lastly, I did want to bring up, yes, some of us, there are opportunities through pharmaceutical companies too to get funding, but there can often be, biases that may that may exist, or their priorities may really be focused on interventions that are related to a drug or other things or a device that may that are often costly, or they may not also look at like other drugs, like a comparison between one drug to another drug. So there are limitations there. So those are all the slides that I had. So sorry to take that time. So
Thank you. And so Matt, you're up next. So Matt, we're in a moment where everybody's being forced to rethink how they operate. What are you doing inside your organization to make sure people, especially uninsured individuals, still get the care they need?
Okay, well, all right. So thank you, Dr. Renee. And I do have a couple of slides that I put together just to go over some basic information. And similar to what Sharmili said, I mean, a lot of what I'm gonna say is gonna resonate with that. But there's basically like 3 strands that are kind of going through this. I mean, one is the people who are uninsured and have been for a while, and like, how do we make sure that care is available to that group of people? The second question is for people who recently lost insurance, or people who are losing it to redetermination, which has always been a factor, but has escalated now and will get worse because of what Christina shared. How do we make sure that people can redetermine quickly if they are eligible for Medicaid? And then how do we support people in between that redetermination process? So like when their insurance is lapsed and because they have a chronic condition, they still need access to medication. And then the third one is which has always been a problem, is how do you care for people who are underinsured, or who have insurance but don't have a place that will accept their insurance within a reasonable distance? And all 3 of those groups, I feel like there's a different juggling act that people have to do. And and then there's also the difference between a free clinic like Mobile Care Chicago, and how do we grapple with that? And then SQHCs and other, or federally qualified health centers and other sort of clinics that might be dealing with that in a different way, alongside direct cuts from the federal government. So, I mean, there's a whole set of kind of strategic clinical decisions that we've had to make in order to accommodate those different threads. I can talk a little bit about that, and I can go into it in the question and answer as well. But I imagine that for many folks who are on this call, part of what you're also grappling with is what Sharmili was getting at the end of her presentation, which is both cuts to direct infrastructure, clinical infrastructure, as well as cuts to research, and sort of like our ability to understand and iterate around asthma issues, And then there's also the sort of like ecosystem effect that's sort of happening with everything else that is politically through this administration, and then also socially or culturally post-pandemic that we're also dealing with. And so I also wanted to spend a little bit of time talking about that because, I mean, not saying that we have a lot of answers, but we do have some context and some insights that we can share just on how we're thinking about resiliency. And because there's a lot of emphasis on diversification, I also just wanted to talk about like, what does that mean in terms of fundraising? So let's see. I mean, I won't go, I certainly won't read out this whole paragraph about mobile care's history. Maybe what I'll just briefly mention in context is that, so we operate asthma and allergy clinics. They are free clinics. We are a specialty practice. We've been around for 25 years, and the vast majority of what we do is we partner with local schools in areas where allergists or pulmonologists are not readily available. And then we provide ongoing or follow-up care for people who have asthma or allergies. There's a lot more I could say about that. That's a very truncated version of what we do in our clinics, but that's the part that's, I think, sort of germane to this discussion. And our mission more broadly is to just make sure that all people have access to the care that they need, particularly people who have chronic medical conditions. And we focus specifically on asthma, allergy, and dental. And actually, before I move on, maybe I should just mention that the reason why we focus on these two in particular is because asthma is the #1 driver of preventable emergency department visits for children. And dental caries is the #1 or most preventable cause of medical school absenteeism for kids in the area that we're serving. So, I mean, I had 2 full slides on current headwinds, and I significantly cut it down. You could go on and on about this, and in fact, many of the presentations listed many more. But I would say, like, what comes top of mind for the type of work that we're doing is, first of all, chronic disease management and medical care generally is being deprioritized, both in terms of like the sort of public sphere, but specifically in terms of like what funders are looking to fund. You know, there's been within the past 3 years post-pandemic a significant shift in people who used to fund health pretty exclusively and are now transitioning out of providing funding in that space. So it's not just about administrative policies or cuts to Medicaid and stuff like that. It's also foundation and philanthropic support that is being affected by this. There's also a consolidation of healthcare infrastructure and creating some access points in which people don't feel comfortable or don't feel heard. I mean, you know, some entities, especially like very large systems, like reputation plays into whether or not people will access care from those facilities within their neighborhood, or will go out of their way to try to access care in those facilities. And so, you know, there is reluctance to enter some medical spaces based on past experience. Funders passionate about these issues are spread thin, which I think gets directly to what Sharmili was talking about before. And this is certainly true of what we've experienced. And for context, you know, since we are a free clinic, over 65% of our funding comes from philanthropic sources. And so, you know, like as more and more people are trying to diversify revenue by submitting grant applications, you know, that pipeline gets harder to work through, and the limited staff at these foundations are more overworked, and it takes them longer to make decisions and makes it more difficult for folks to get through the system. And of course, foundations are trying their best, and they're doing, by and large, a fantastic job of trying to accommodate a lot of factors outside of their control, but it is an issue. And our most vulnerable neighbors continue to have issues getting access to health insurance. That was true before. It's been made worse by the termination of HBIA. I imagine that that will continue to get worse and more complicated. I would say for us, there's also a perception by some that conditions are improving. And, you know, that can be a sort of like misinterpretation of research saying like, you know, emergency department use is generally going down, asthma fatalities are generally going down. And sort of like, you know, there's an undercurrent there that access issues continue to diverge widely along lines of race and geography. And so, you know, within your specific region, maybe there is some reason to believe that conditions have improved, but that's not necessarily true generally. And so it's harder to engage donors and other people about those issues when in their mind you're talking to them about an issue that is not necessarily urgent. And then the last thing I say is just like this list is not exhaustive at all, but I do have to move on. I can't just list them forever, and I easily could go on for a while. But for those of you who are in the chat, particularly the folks who were presenting before, I know you're very familiar with a lot of the other headwinds that we're experiencing right now, and if you want to put them in the chat, we can talk about those as well. But I really wanted to move into the sort of next space, which is like, okay, given the reality that we're in, and also the fact that, you know, when situations get worse, that doesn't mean that people with chronic diseases magically lose their chronic disease. So how do we continue to support people who have asthma and related conditions in this environment? And that gets to like, how do we think about resiliency? And particularly when we're talking about like sustaining funding for this work, what does resiliency look like? And, you know, it seems to me with at least the organizations I'm familiar with that I associate with being resilient, the first one is adaptability, and being able to understand that, you know, within this environment, you know, the needs of people are going to change, and also the way that people will desire to access resources will also probably change. And so adaptation that's driven by people who are in the community or who are benefiting from various interventions, you know, keeping that through line and reinforcing it can make organizations stronger even in times that are adverse. And also keeping a clear understanding of context. Like there are a lot of factors affecting access to healthcare currently. Most are, you know, not really going our way, but there are some that there are some movements that are positive. And keeping that context in mind and making sure to stay grounded in the very specific neighborhoods and lived experiences of people who are benefiting from the work that's being done. And that gets to inclusive decision making and making sure that, you know, even among a lot of very difficult decisions, that the things that are most valuable and sort of like most sought after by the community, that those things are sustained and are kept strong. And strong communication about that decision-making process and stewardship of current stakeholders, because you know, I would say for any project that's going on, there is a group of people who is interested in making sure that this project is sustained, and making sure that communication with that group is prioritized, even in the face of that group maybe not being enough to meet the complete need for funding. I think it's one part that I often see organizations neglect. And yet that group can be the strongest advocates for the work that we're doing, and can amplify a lot of the work that we're doing or will need to do in the future. and I'm going to keep this really brief, but of course, like I can talk in more detail in the question and answer session about like, okay, if that's resiliency, then what does diversification look like? And specifically in terms of fundraising, revenue generation, whatever you want to call it, like what does diversification actually mean? Because I think a lot of people, or at least the way I hear people talk about it and the way I hear people in fundraising specifically act on it is that, you know, you just start throwing stuff at the dartboard and you're like, well, I guess I'm going to do a list or a search of these, like whatever foundations fund health, I'm just going to submit to all of them. And that can be immensely labor intensive and can have very little value. And so, you know, for my development team and the way that we've onboarded development folks for years, and of course my background is as a fundraiser, is first of all, slow intentional movement towards areas made possible by relationships is always going to be the sort of pathway that can get you the most amount of reward for the amount of time you're able to contribute. And so that's why I say stewardship really becomes the foundation of how you get through hard times and create new opportunities, is talking with folks and seeing who else they might know, who you might be able to talk to, or who might know of an opportunity that ultimately might, lead to funding or might lead to connections or something else that might help you out. And granted, I know some folks on here are part of like large hospital systems, and so your fundraising department might not be as agile. I get that. But even within that, I think stewardship becomes really important. The second one is collaboration and joint funding. And I think for most of us who are in community-based clinics, this was the major lesson of both the Rauner years and the pandemic, is that survival really depends on all of us working together, coordinating our efforts, and then finding a way to make sure that funders realize how tied together we are. That like an asthma clinic cannot exist without primary care. You know, we are an ecosystem, and that ecosystem itself needs funding. And then strategic reflection, particularly about what parts of the project is most valuable and relevant to the community. And as I said, making sure to put that front of mind and make sure that the community understands that that's where your focus is. So that you can make sure that you maintain that trust and that alignment, even in a time where, cuts might need to be made. And then lastly, an assessment of current assets, particularly stakeholders. I really hate using the word assets. I try never to do it. I think this is one of the few circumstances in which this word is appropriate, because particularly for like, small projects within larger systems, I think in times of disruption, it can be easy to overlook the sort of like synergies, the assets, the connective points that you currently have, and particularly with stakeholders that you take for granted because you talk with them all the time. And so, literally documenting, who are you meeting with? What is the way that they interface with these projects? What do they, in what way do they care about people with asthma? And what are the sort of resonant features of that particular relationship? Those are assets. That is something that has been built over time that other organizations would not be able to easily replicate. And so making sure that those are prioritized in the conversation, I think also helps to better align fundraising and hopefully make for circumstances in which at least your most valuable work can be like not only protected but grown and iterated on. And then the last thing that I say down here in the sun area is that each project is different, but each one usually has a strength area that brings funding in. And so for an organization like Mobile Care, like I said, we are largely dependent on philanthropy. I mean, that just is the reality of the way that we exist. And other projects or other institutions, other programs will be funded in a different way, but they've built up a skill set that makes them highly competitive within that particular sphere. And that's worth defining out loud and worth understanding, like how does that particular mechanism or machine help you to be sustainable? And like, what does it look like to continue to use that asset in the way that it's been calibrated? So, with that, those are some very basic thoughts I know about just like how we're going about thinking about this time. And again, I can get into more specifics if people are interested in that, or can talk more specifically about resiliency exercises as well. But in the interim, that's the end of my presentation. So I'll send it back to you, Dr. Renee.
Thank you, Matt. Next up, we have Gloria Seals, Community Education and Support is what she's going to talk about.
Good afternoon. Thank you so much for having me here today. I first want to convey a really important message on how important CHWs are in the healthcare system. They are imperative when it comes to this system and the times that we're living in right now. They are able to make an impact on children, parents, adults, entire families. So our world is growing and developing by leaps and bounds, and we're hoping to integrate into all systems in all hospitals if possible. So I really want that message to be heard, that community health workers are the key to some of the things I heard earlier today. I heard a lot of information about housing and reaching patients where they are. So I am just really glad to be here. I have very few slides because I want to just talk on the panel. So with that, I want to go to the first slide. Thank you. Okay, so supporting our communities in challenging times, and indeed we are in challenging times. What does support look like to us today in this current climate? Well, we work in a safety net hospital system where most of our patients, about 70% of our patients, rely on public health, public charity, or free clinics. So we're working directly with those patients and trying to help them navigate the system. Many of our patients that we see face social and economic barriers, including unemployment, which is extremely high right now in Illinois, and it has been that way for some time. And in my caseloads alone, I think 50% of the patients that I have in my caseload are unemployed. Then we have the housing instability. Well, I've been working in healthcare and in asthma for over the past 25 years. And instability in housing and limited housing has been an issue for the last 10 years. So we're trying to help patients and families get into decent, affordable housing as well. And then we know that those people have limited access to food, especially now since we have the cuts in food stamps and the cuts in food supplies. So we know that transportation is also one of the major issues with our patients, because oftentimes we find they don't make it to appointments because they don't have transportation. And some of them aren't even aware that if they just flip over the insurance card that they do have, that the insurance company provides a ride for them. So these are some of the things that community health workers address time and time again with patients because they just simply do not know. We have established creative partnerships with multiple community organizations to address some of these health-related social needs. For example, we have a relationship with CAC over, I think, the last 2 decades for sure, where they give us resources for education, supplies and materials, and they give us updated information on medications and tools on asthma management. And this is so very important because my main area that I work in here at SUHI is within asthma. And so we need current and updated information constantly because our patients will lose medication, don't have medication. They don't understand how to use each medication. Oftentimes they don't know how to use the devices, and they don't even know how to set up appointments to go back once their medication has been, sometimes the doctor will cancel one medication and start a new one. And oftentimes when I get to the home, they're still using all of those medications, or they're not using any of those medications. So the help from the CAC is really important. Also, we have a partnership with MTO, which is the tenants' rights, which she spoke about earlier. Thank you, Dr. Patel, I think, and a few other people talked about that. Well, the Tenants' Rights Organization is an organization that supports tenants in their homes, because I conduct home visits, and I will tell you, I have seen homes that were infested with mold, mildew, insects, pests. And so it's really important to have a connection with MTO, because they make sure that tenants know their rights. And so that's really an important partnership. And more recently, we have partnered with Belvery, and it is it is also a food pantry type app that we use that gives our patients delivery. They deliver groceries to our patients twice a month, every month for a full year. So they offer a lot of coverage in terms of food and groceries. And in these times, with all of the cuts in the system, it is really, really imperative that they have these types of programs available to them for those people that are eligible for the program. Also, I'd like to make sure that I mention IDPH is one of our funders as well. They're allowing us to conduct these home visits and go into the homes and take care of the patients and meeting them where they are. That's the most important thing that community health workers can do. They have the time to sit down and talk to patients and make sure that they have what they need. And if not, then we resource them out. What we're doing now is so very imperative in the healthcare system. Next slide. So now CHW adapting to system changes. As we know, with the big, beautiful bill, there's been a lot of changes. And so the CHW role is ever evolving as healthcare systems adjust to new funding, coverage, and cuts. More patients require help from CHWs to navigate the insurance and get financial clearance and get their medication. So our role is imperative when it comes to all of these new cuts that we were talking about previously, because with the CHW available, they can help them navigate through that system and refer them out to whoever they need support from. So this is a really key part of our role at this time. CHWs are increasingly key to helping patients connect to insurance and income-based programs. Now, we literally are like the liaison. We bring patients that have been lost in the system, we bring them back to care, and we are conducting outreach so that we can call patients that haven't been in the system for quite a while, or outreach when we're in the community. We meet patients that said, some of our patients in the community will say, we'll ask them, have you had a mammogram in the last year? And what they'll say is, oh, I haven't had a mammogram in about 5 years. So we have a department that we can bring those patients back into the system, get their mammogram so that they can have peace of mind, or if they need treatment of any sort, we are able to get them and navigate them through that system. We're also making appointments. Community health workers schedule appointments for patients, and we are integrated into the healthcare system here at Sinai Health System and Sinai Urban Health Institute. We've integrated them into many different departments here. And what we're finding is all the departments need community health workers, because we can catch and those people that fall through the cracks. So it's really important that they're integrated into all different systems. So we also do follow-up care after a hospital discharge to support continuity of care. Because what we're finding is continuity of care. What we're finding is patients are eager to go home. They don't want to be in the hospital, so they're eager to go home. So what we want to do is make sure that when they get home, they have what they need in order to thrive and work through their health issues. So when we call after 2 or 3 days after their discharge, we find people saying, oh, I didn't realize now that I've had the surgery on my leg, I need a wheelchair, or I can't get up and get to the washroom, I need a bedside commode, or I feel like I need oxygen. These are things that CHWs will call and find out and give them resources and connect them with different departments that could potentially save their lives. So it's really important that we conduct these follow-up calls after each discharge. We also, one of the main things that we do here at Sinai Urban Health Institute is collect data, because data and reporting shows the impact that each in all, as a collective, all of the CHWs have on a healthcare system. And we also are able to show where we are able to decrease hospitalizations, decrease ED visits, because oftentimes if a community health educator connects with a patient, we can get them back into the system so that they can see their doctor as opposed to going through the ED, because we find that oftentimes people utilize the ED just to see a doctor when we want them to see several doctors through the year to prevent those ED visits and those hospitalization, inpatient hospitalization. So what I'm going to do on the next slide, like I said, I didn't have many because I want to speak on the panel and answer questions. I want to tell you all a story. I want to share this story with you. It's a CHW impact story. It's a story of a patient that I have. It's a story of trust and transformation. I have a 42-year-old Latina patient recently displaced by domestic violence with uncontrolled asthma and no insurance. Now, I want to pause there for a minute to talk about this patient. She allowed me to come to her home, and what I discovered at that point was she had literally fled from Houston, Texas, to escape the domestic violence situation that she was in. She fled with no ID, no birth certificate, no passport, nothing. So she's here in Chicago, but she's feeling much safer, is what she explained to me. But as her CHW, I had to deal with her holistically. I had to give her support holistically. So I was able to refer her to an to a clinic that was a free clinic for her to initially see the doctor, because she didn't have insurance and she wasn't able to just go anywhere because she doesn't have an ID right now. And I was also able to connect her with the insurance department to make sure that once we get her ID, which I also connected her with someone to help her, support her with getting her ID. I had to connect her with Quit Smoking hotline, because she told me at this point, because of the domestic violence situation she was in, she was smoking pretty heavily. So we talked about that, but I knew that wasn't something to address on the first day. But as I build the relationship and the trust, I was able to move her to that point. I connected her to the Vivery and Nectar, which was the app for the food for delivery twice a month at their home for at least a full year. So that takes care of the part where she isn't currently employed. She was struggling to eat. So she needed some additional support with just simple plain grocery and produce. So I was able to build this trust and an ongoing engagement with her, despite her fears of leaving home due to immigration concerns. Now, she is a US citizen. However, in the safe space where she is right now, her partner is undocumented. So she's afraid to leave her home. He's afraid to leave the home. So she trusts me to come into her home and bring whatever I can, and anyone that I actually support and ask to get in contact with her or go to her home. But mostly I am the only one that's been in her home since she's been here in Chicago. And she says she feels safer here than she's felt in a long time for two reasons. One, because of the situation she was in, and two, because there were open carry in Houston. So she felt like everyone was carrying guns. And so she felt unsafe in her home as well as unsafe outside of her home. So through my support, I was able to have her. Right now, she is able to wait for her insurance to clear. She has food, so she can feed her family and her partner. And then at some point, at this point, she says she's ready to quit smoking, which will then help her improve both her health and the stability of her family. But this is one of many, many stories that all of our CHWs here and across Chicago can tell you about what we run into when we go into homes. We never know what we're going to experience or what kind of information we're going to get, what kinds of situations people are in, from houses that they shouldn't be in, but landlords are putting them in houses because they're able to and because they're desperate, to people who are in domestic violence situations, to people who are homeless. So the CHW is really, really key to supporting the healthcare system overall. I mean, with nurses, doctors, they all have their role, and CHWs have a true imperative and a role that has a very positive effect on children, on parents, on schools, adults. We are able to get children back into care, families back into care, and get these children back into school, especially those that have uncontrolled asthma. We managed to help them get their asthma controlled and managed and back in school. So that's my spiel. And I just wanted to leave time for the panel. That's really what I wanted to do at this time. And that's why I didn't have many, but I have many stories to tell if you all have questions. So thank you so much for allowing us to be here today, especially me representing Sinai Health System. Thank you.
Thank you, Gloria. If there's any questions, please place those in the chat. This question is for you, Gloria. Were you able to help this patient with a domestic violence organization?
Yes, but right now she's away from the actual partner that this was occurring with, but we did connect them. I did let her know about our programs here in Chicago. I think her major concern, I think at this point, was getting ID again and being able to identify herself. Our roles have pivoted I think that's for me. I believe our roles have really pivoted because we have had to change over to not just giving out information about asthma and other diseases, but we've had to help people who are losing their insurance, and now they need support with filling out insurance papers and trying to reapply in the system. And so we've had to change from what we're actually coming in the home to do to support people in those areas like insurance and ID. For instance, this young lady had no ID. So we've had to pivot, but we will not pivot. What we won't pivot on is treatment and care for patients. That's one of the most important things that we feel is important with supporting patients who feel like they have no other option. So we are concentrating mainly on making sure they have housing and food and shelter.
Matt talked a bit about philanthropic funding. What other options are there for more CHW support and expansion? I think that's for you, Gloria.
I'm sorry, I didn't hear that. I'm sorry.
What other options are there for more CHW support and expansion?
Well, we are inside of Sinai Urban Health Institute. We've been integrated, and we're right now in talks with several other partners to get more CHWs hired, because most of the time they have to be hired through funding that is supplied for community health workers. So at this time, we're looking to work directly with our outside partners to bring in funding to hire more CHWs, both bilingual and for both the communities that we sit between, which is the North and South Lawndale area.
And Matt wanted to know, did Illinois ever implement reimbursement for CHWs?
We're in talks right now for that. Well, I think what's been happening in the last decade or so is that as we partner with people, the CHW role is written into the grants and in funding. So we're able to pay salaries and hire people in that manner. But we are still right now in talks about having reimbursement for CHWs.
And this is for any of the panelists, just a general question. Given the new work requirements for Medicaid, especially the twice yearly certification, is anyone working to develop an infrastructure to assist people with these administrative tasks to ensure that they remain eligible?
This is Christina. I can try to answer part of that. HFS recently testified at a subject matter hearing in the Illinois House a few weeks ago. So they shared some of their updates on how they're trying to get ahead of all the changes that are coming. They are working on a short-term and a long-term communications plan to make sure that communication is early and ample for Medicaid enrollees. They also shared that they have a lot of lessons learned from COVID and the redeterminations and unwinding that happened under COVID-19, that they know some things that they're going to avoid doing. And then they also have ideas for how they can reuse some of those tactics that were successful once they kind of got through the difficult periods of Medicaid unwinding. And I can tell you that HFS is a top priority for them to make this as seamless as possible for patients. Health organizations like the Lung Association are really pushing for them to apply as many exemptions as they can for enrollees from the work reporting requirements. And we anticipate that there probably will be public comment periods as well to get input from the public about proposed changes. So those are just some of the pieces that I'm aware of so far. It's definitely, these are huge changes, and it's all a work in progress in terms of kind of developing a plan to keep as many people eligible as possible.
Thank you, Christina. Matt, are you seeing an increase in your patient load at Mobile Care Chicago?
Okay, so Rochelle, that's a complicated question, and in part because of just like the way that our mobile clinics operate. The beginning of the school year, we would typically expect to see a lot of new patients anyway, because kids are enrolling in different schools, or perhaps they're talking with someone else who is using the asthma van, and so they end up getting connected to us. And so it's unclear at this particular time how much of our enrollment is coming from the sort of like natural process of people talking to each other or trying to get access to resources, and how much of it is from like people having either already had their insurance disrupted, or people who are thinking that further disruptions are going to happen. I guess the other kind of factors that we'll be kind of looking at later is, first of all, and I mean, Christina did such an awesome job talking about this, but the effective redetermination is real. I mean, it's very frustrating for people. It is not a straightforward process, and especially if you are moving addresses pretty frequently, your redetermination notices might not reach you before the time that your insurance lapses, if it reaches you at all. So, this is, it is a real concern. And every year we see that there are like some people who would otherwise qualify for benefits who, you know, their insurance lapsed and now they're like kind of looking around for a free clinic just to like be a stopgap until they can get something else. And then ultimately what usually happens is that they end up staying on at Mobile Care to be their asthma and allergy provider, and then they use the PCP for other stuff. So, you know, that's a factor that we're going to have to pay attention to, and we probably won't know for a while what the full ramifications of all of this is. And then the other part of that is just like I guess maybe like the general tenor or the rhetoric or the sort of like effect of everything that's been happening with people being abducted by ICE, and just generally like the way that people are like being cautious about moving around their environment, and like what effect does that play in people's access to healthcare. We are doing quite a lot of telehealth appointments, and I think one of the things we'll have to monitor long term is like how many people continue to use telehealth, or how many people are not sending their kids to school, versus how many people are able to access other medical or health infrastructure or feel more comfortable traveling around. So yeah, I guess that was a long way of saying I don't have a good answer for you.
It's okay. Thanks a lot. Christina has dropped into the chat resource page, a federal resource page that with the implications of HR 1. So please, if you need to get a copy of that link, it's in the chat. Are there any other questions? If not, we have a lovely evaluation we would love for you to fill out. So here's the QR code for the evaluation. Please either use your phone now and get it, or take a screenshot of it and then go to it later. But please, if you could get this evaluation completed for us, it would really help us out for our spring conference and any other lunch and learns that we do. I put a link to the evaluation in the chat as well in case you can't get the QR code. And thank you for attending. For any more information about the Chicago Asthma Consortium, please visit our website, chicagoasthma.org. And if you have other questions, you can email our association manager at info@chicagoasthma.org. Thank you so much for joining us this afternoon, and everyone have a great day and happy Thanksgiving.